Okay, carpal tunnel syndrome. Who knows what this is? You know, there's a recurrent theme to some of these lectures, which is we don't know what we're talking about. And I'm not sure what to do about it. So what is carpal tunnel syndrome? Well, there clearly is an area in the wrist where the median nerve can be compressed, and it can be compressed for a number of reasons. And when you compress it, you will have symptoms of median nerve compression. So that's true. Now there is a once that happens, it's also true that there are some kids who are really out of control and really hyperactive. And we go somehow from there really is this thing to everyone has carpal tunnel and every child is hyperactive. And you can think of a lot of examples of that type of thing, where we somehow go from a real disease that we know how to define to normal behavior, and normal physical findings is somehow a disease, and we're not sure exactly how to define it. So how do you define carpal tunnel syndrome? Well, the name should be a clue. It's called a syndrome. A syndrome, as far as I know, is a set of clinical findings that suggest a cause. So what are the clinical findings of carpal tunnel syndrome? Median nerve involvement, right? So what's that? So it's mostly sensory on the palm over the area of the median nerve, with exception of the thenar eminence, because the nerve to the thenar eminence branches before you get to the carpal tunnel. So that's spared. So you should have tingling and numbness and funny feeling and some problem with grip, and maybe, if it gets bad, in the areas of the median nerve, this part of the hand, the distal part of the hand, at least the distal 3 fingers, radial fingers, 3.5 fingers. That's what carpal tunnel should be. Now, then after that, everything gets crazy. Why does it get crazy? Well, because you can measure median nerve function. And some people say you have to do electrophysiologic studies to make the diagnosis. But it doesn't work. Why doesn't it work? Who knows? The nervous system is nutty. Our model of the nervous system is clearly wrong. It's not all wrong. A lot of what we know seems to work pretty well. But carpal tunnel is one of my favorite examples. You can have somebody who has clear-cut, everybody agrees, obvious carpal tunnel syndrome, where there's no doubt about it. It's not the iffy case. It's the most obvious case, and they all will have symptoms up their arm. Tell me how that happens. You get a compression here, everything distal. How could you possibly have symptoms proximal? But they do. It doesn't work the way the textbook says it works. And we all know that's true, because anybody who's ever taken care of a patient who fails all of the trick tests we give for conversion disorder, like it crosses midline, or you put their arm over their head and it falls and it doesn't hit their face and all that, they all manage to convert themselves into being dead. They really have, all the things that we make up as rules don't work all the time. And carpal tunnel is a great example of that. So people notice that the electrophysiology, you can find EPS problems with your exam that the patient doesn't have carpal tunnel syndrome. And even more important, you find people who have clear-cut evidence of this problem, and then the testing, the neurotesting, is normal. So what's the gold standard? Well, who knows? I don't know. Is it the syndrome? Is it the clinical stuff? Is it the electrophysiologic testing? Most people agree it shouldn't be testing. What are your other choices for the gold standard? One would be, how well does it respond to therapy? And the definitive therapy is surgery. If the median nerve is compressed, relieve the compression, they get better, right? What's wrong with that? So this chapter actually suggests that the response to surgery may be the best gold standard. I think that is crazy. There are 2 reasons why it's crazy. Why is that? Why is it a bad gold standard? What? 50% of patients who get placebo get better in all the drug studies. So how could, this is a pretty powerful placebo, right? So if it has no effect at all, that wasn't the problem at all, it's still a pretty powerful placebo. So there's going to be a lot of false positives based on that as a gold standard. What about the other side? There's going to be lots of false negatives. Surgery doesn't work in everybody. If there's been enough compression of any nerve over a period of time, you can't get it better. So how could this be the gold standard? Well, absent the gold standard, everything else in this chapter, I don't know what to make of it. Because they're testing people who they claim have the disease, who I'm sure don't, and people who they say don't have the disease, who I'm sure do. So everything is not a little, it's very murky here. We need to know what this is. Now the chapter goes on, the first few articles say there are a lot of diseases associated with carpal tunnel syndrome. You think about it, there's a tight space there, the nerve gets compressed, anything that makes the space tighter, a small hand, a certain type of shape of the hand, certain rheumatologic diseases and diabetes have been associated with this. Also, repetitive activity has been associated with it. But we don't really know what the relation of any of these is because we don't have a good gold standard. Now in America, where everybody knows about carpal tunnel syndrome, particularly if you have a certain type of repetitive behavior, now it's work-related. Well, is it work-related? I don't know. There's no gold standard. There are a couple articles in here. Number 2, I think, is the one in particular, argues it can't be the primary factor. Because if you go to different places where there's no compensation for carpal tunnel syndrome, people complain of the symptoms much, much less with the same job. So I'm sure that's true, but does it contribute? I'm sure it does. What about other things? There's a couple of really silly papers here which look at the association of other diseases. And they say, some people who have it have a high blood sugar, and they didn't know they had a high blood sugar. It proves that diabetes is associated. This is nuts. There's no proof at all. It's basically we like to think that maybe there's an association, so we find what we want to find. But there's no evidence about any of this. Again, this is very common. It's getting more common in the United States. It's enormously common. It's higher in certain complaints are higher in certain work groups, but we don't know what it means. And this literature does not help, I assure you. The next thing is, how do you do provocative tests? There's here from 5 to 16, 15 or 13 are all about provocative tests. We all know what these tests are, right? The Tinel's, you tap on it, Phelan's, you compress it. There's a whole bunch of variations that you will see in here. We just did one of how you raise your hand and hold it in a certain way. There's all sorts of variations, and they all work how well? Well, in order to know how well they work, what do you have to have? You have to have a gold standard. You have to know which patient has the disease and which doesn't. And very often, you know how we know? We did the test. And if you also look at these, when Tinel described the Tinel's test, how good was it? It was almost perfect. When Phelan described Phelan's, it was almost perfect. Every time you get retesting the same thing, it gets worse. So all the new tests that are now much better, trust me, they're going to get worse when somebody comes up with another test. And none of these are very good, and they all suffer from the same problem, which is we don't know which one really has it. So I don't really make much of it. What can you do in order to help yourself try to make this diagnosis? There is no gold standard. There is no way. I think there are some cases where I know it has nothing to do with the median nerve. There are other cases where I'm sure it's the median nerve. And I think carpal tunnel, if they have symptoms that are clearly in the 3.5 fingers of the palm, and they're mostly sensory and may have some little problems with grip, and spare the thenar eminence, that's probably the median nerve. And everything else, you can do these tests, you can do whatever you want, you're going to be making it up. Now, what should you do about it? In the patient who you really think has the disease, really has the problem, Well, there are a couple of things which say splinting in neutral seems to be a good idea. Splinting in neutral position. There are a few things about various nostrums like NSAIDs and steroids. And you can read them. There are 3 or 4 articles in here. There are many in the literature. And what do they show? They're all over the board. Depending upon which one you're pushing, the other guy, the comparator, is less good. When you're pushing steroids, look how good steroids are. When you're pushing NSAIDs, steroids aren't any good. NSAIDs are just as good. When you're pushing a splint, the splint was better than steroids. And then what about surgery? Same stuff. Surgery is, there's number 20, I think, is the best of these. Compares steroids and surgery. Early on, steroids were much better. 94% were better at 3 months, where surgery, only 3/4 were better. Remember, placebo is 50%. By 6 months, it was 86% versus 3/4, and by a year, it was 70% versus 3/4. We could go through the same numbers for all of these other papers. Remember, they're very questionable because we don't even know what the gold standard is. So you have somebody who comes in, they have it. I think it's rational to try them for a short period in a neutral splint. Number 17 and 18 are both about splinting, and if you want to look at them, they sort of suggest how some people like to do it. You can try them in a splint for some period of time. You could try them on steroids if it's really, really bothersome and they're not getting better with the splint. But, you know, I don't know. How many have been on steroids in this room? How many like it? It's, you know, we always think of steroids as it's no big deal. But I've been on steroids a couple of times, and I hated it. I hated the feeling of being on steroids. I hated being manic. It was terrible. Anyway, so you could try that. And then surgery is sort of like, I think, should be reserved. The surgeons like it, but I would say it should be reserved for those cases where you really think they have the disease and they're really troublesome and they're not responding to other things. But this is a chronic condition which doesn't, you know, there's going to be at least 1/4 to half the patients are going to have bad outcomes. No, no.
Do you remember the radioelectronitis injection paper? That really hit me and stuck in my brain. I used to inject radioelectronitis all the time, not think about it. And it was a pretty small study, but I think it was pretty well done, showing that the steroid group did worse than benign neglect or therapy.
So, it's a really good comment, and I probably should have made this comment. The comment was, there's no placebo group or control group where we didn't do anything in a lot of these papers, and that's true. And when you say, oh, 70% did better, how many would have done better if you just left them alone? Again, placebo in some of these studies is 50%. So the difference is at most small. The second thing is, we could look at other literature, not just the carpal tunnel literature, to give us some idea about steroids. And she mentions the radial epicondylitis paper, which showed that putting a steroid into it actually was bad. It wasn't neutral, it was bad. Well, there's lots of studies which show, one of my favorite ones is the one where they used shoulder bursitis, and they compared putting steroids into the shoulder and putting steroids into the butt. And they were the same. And that study didn't have a put placebo into the butt. See how that does. So a lot of our steroid stuff for orthopedic conditions and neurologic conditions is very, at best, marginal. And we don't really know. And again, I apologize. I wish I could tell you, here's the thing to do, here's the answer. But I think the carpal tunnel literature, there is no answers. What do you guys do? How about the primary care docs? You guys see an emergency, it's much easier for us. We just say, oh, it could be carpal tunnels. Go to your primary care doctor. What do you guys do? Send him back to the emergency room. What do you do?
Nighttime splint.
Nighttime splint. What else? Who does that? You all do that? What else do you do?
People that are really bothered, we've been doing short courses of oral steroids. And, you know, unstudied, anecdotal, but it seems like that helps when people
So people who are really bad, try some steroids, which sounds reasonable. But again, how about if you just tried some, you talked to them very nicely, and you tried some placebo? You know, I don't know. Other comments?
Then they don't come back because they don't like the way the steroid block.
That's really good. Give them aversive conditioning. You come back to the doctor, we will hurt you. Way in the back, go ahead.
I can give a testimonial of that by that for carpal tunnel, but I think the problem is by definition. If the patient will clearly have carpal tunnel and it's obvious, then I think they need to go for surgery, and I will temporarily tell them to use splinting and not steroids. But I think including a lot of other, say, peripheral neuropathies, and maybe that was confusing our results.
So the comment, I think, is that if they really have the disease, surgery probably is beneficial. And I think that's probably true. And there are many patients where it's who knows what it is, and surgery probably gets a little bit of a worse name because you do the surgery on the wrong person. Of course, it's not going to work. And I think there's probably truth to that. But like anything, so I don't think this is as bad as surgery for backs, for example. But I do think but even in the right person, it's not going to be perfect. And certainly if you're doing it in the wrong people because this is such a murky diagnosis, it ain't going to work. I don't think there's any easy answer.
In carpal tunnel, which may be work-related, where they're doing repetitive type movements, would putting a splint on help, or any information?
So what about where you think it is work-related? I don't know the answer. I have no idea whether... I'm sure there are people where they need rest, and you need to splint them, and you need to get them away from doing that work. So if they're doing repeated, that type of work, and they have clearly carpal tunnel, I assume that the primary care people are giving them some break from the work and advice about not doing that type of thing. But how well it works, I don't know.
How long do you give them?
And how long? Should it be for a month? When they go back, it's going to get worse again? We're talking about livelihoods, and then there's the whole problem of, is it disability, and that we know that's a quagmire. How long are they going to use steroids? Most of these are for, how long do you use steroids for? A week? Something like that?
I think this discussion is very helpful because we have a duty to educate our patients, and I think it's helpful to tell them that there's no clear-cut cause, and to be dubious about the treatment and challenge the recommendations of somebody. I think it is helpful, although
Good.
it's unclear.
Thank you. So I'll just repeat what he said because I'm glad. Rick and I argue about this all the time. Rick says you have to have 40 great papers every month. And I go, there aren't 40 great papers. What do you want me to do? I can't call them great when they're lousy. And I got the microphone now. But he's going to get it in a second, so he's going to but I think it is important. Sometimes people say, we want an answer. I really want to know what the answer is. But it's also, he's suggesting that sometimes it's important to know there is no answer because we can tell our patients that, and that's maybe the most important thing we can tell them. And I really believe that. So although I apologize that I can't just give you 3 things to go home and make it better, I think it is useful to know when, in medicine, as happens all the time, we're not sure what we're doing.
As far as a job modification, most of the times the patient will tell you when they're ready to go back, and oftentimes they're coming in, their symptoms really aren't as bad. They're coming in because they have something. They're not really coming in because they want necessary treatment for it. They just want to know what it is.
Right.
And, they'll find, if that's what it is, it's really not that bad, I'll work with it. And it doesn't get a lot worse a lot of times.
Absolutely. Go ahead.
Just some of the some physicians I've worked with, just doing case reviews on daytime splinting, have been showing a nice trend towards harm for daytime splinting. And they're doing workman's comp reviews over California, Nevada, and Utah.
So the comment is that there may be, that daytime splinting may not be good. In fact, it may even be negative.
In what way? Atrophy?
They show decreased function and decreased ability to go back to work.
This is so messy. I don't know what the answer is. But this is one of those places where probably for a lot of your patients, just sort of individually working it out with them can help them, even though we don't know what we're dealing with and we're not fixing the disease. A lot of it probably depends upon who the patient is and what they want, what they need.